Welcome to this afternoon at NESA. I think now we have the right point of energy to enjoy these presentations. The first one is titled NESA Knife. When to operate or when to modulate in spinal pathology. To do this, we have the perfect fit. He's a neurosurgeon at the Hospital de Levante, Spain, specialist in cranial, spine, and peripheral nerve surgery, and currently he's doing his PhD in neuroscience. He is the clear example of integrity in therapy, of teamwork, and he has great hands. So it's a pleasure to introduce you to Santiago Garfias. So we have had lunch. Now I would like to invite you to do a trip together. So think in something you like to do, something requiring some physical activity, maybe moderate, because it could be that maybe you have sons, daughters, or grandsons or granddaughters, and you like to be with them, but maybe you like going to the movies or going for lunch or for dinner with friends. Now, with this in mind, think, please, that something goes wrong. Imagine that now you cannot enjoy this activity the same way as planned due to pain. So due to the pain, you stop being with your son, with your daughter, with your grandsons and granddaughters. Now you cannot go for lunch. Now you cannot go for dinner. Now you cannot go to the movies because you're suffering this pain. But maybe even you cannot sleep well. Well, this is what I see every day in my clinic. I see these patients going from one place to the other, looking for an alternative with pharmacologic treatments at a very high level, rehabilitation treatment during a long time. And they are looking for the surgeon, maybe as an option. They didn't like to go, but it could be an alternative. Many times these patients, also at the surgical level, we find this hesitation, I mean, these doubts, what treatment we should give to the patient. And here I got to know neuromodulation. I think we have a diverse group of people here, psychologists, doctors, physiotherapists, and we all are looking for something to offer our patients to improve their condition, to improve their quality of life. I think that only from humility and recognizing that we all can learn, we can have this approach to give a good treatment to our patients. And why should we talk about spinal pathology? So please raise your hands, those of you who had some cervical or lumbar pain. As you can see, it is a very widespread pathology. At the world level, prevalence is 7.5%. If we translate this into numbers, into figures, the WHO thinks we have 17 million people with this pathology. To contextualize this, 170 millions, 7 times the population of Spain, 8 times the population of Germany, 9 times the population of the UK, twice the population of the United States. This is 700 million people, and distributed between genders. It affects all the population of all ages, especially 35 to 50. And not only that, who of you has seen some medical leave of your staff lately? Well, this is a disease that in the developed countries is the main reason for medical leaves. leading to millions and millions in losses. But if we talk about spinal pathology, I mean, this is very diverse. It is not just one alteration. We can find acute alterations, like a hernia, triggering a pain that the patient didn't have. And in some cases, we can have we can deal with pharmacological treatment. But then we have these patients with a chronic pathology where this pain is different. At the level of surgery, we can have two points of view. We could either try to have this data of instability of the spine, I mean, to have them corrected, or we can try to find another alternative, trying to be less aggressive for long arthrosis, for example, to surgery like, for example, knee or shoulder arthroscopy. But we could do something even less invasive, could we? We must understand that the spine is a very specific structure. It doesn't only have one source of pain. We have different joints in the body. So the pain does not only come from the joints, also from the disc, also from a compression of the nerve. So we must understand that we have to see the patient in a very meticulous way. But when we see innervation, here it comes to play the autonomic nervous system because from sympathetic fibers, we should transform the spinal plexus because we have innervation to the disc and the spinal plates. And most of them, I mean, the source of this pain is in this vertebral spinal discs or plates. But this is a physiological process where we will have a change of the content of the, I mean, necrosis, concentration of, so the disc cannot bear these axial loads and become dehydrated. And this is what we will see now. On one side, we have a healthy disc that at the level of image, we see this has a good content, no protrusion. And then on the right side, we have a dehydrated disc, a degenerative disc with osteocytes. And this all will condition local pain and a decompression of the nervous structures. And then we will have this pain. Well, what happens when this acute pain is chronic, it becomes chronic? It has a different representation. It's not only the sensorial part, it is also an emotional part. So we have to take into account another brain circuits. The cingulus as a main one. We shouldn't forget about the insula, the amygdala, and all this will play a role, a very important role in this pain. So not only the component of the pain we have now, but also the emotional component and the cognitive component, through which, I mean, we can also act in that to improve the condition of the patient. But the structural alteration of the spine produces or triggers symptoms. Studies made in people with no pain prove this. We all here are between 30 and 40 years old. So at least 50% has some alteration in the magnetic resonance. I mean, let's not talk about those of aged 80. They all have alterations, but have no pain. What other things we have to take into account? Well, different factors. And here it is very important, the heart rate variability, but also alterations in sleep disorders, and also the emotional state. So, for example, you see, this patient is must only not be seen from the medical aspect, but also the sleep and the emotional part. Let's see them one by one. So the heart rate variability at the level of spine, we don't have much analysis, but for more than 20 years, we have had this study proving that patients value of in this scale they have here? Well, they have a less variability of the heart rate. And not only that, they had a lower parasympathetic tone. We have more recent studies only comparing the parasympathetic tone between patients that have gone through surgery and those who have not. And what happens with sleep? One could think, well, if someone has pain, I mean, they will not sleep well. But they valued assess two different things. On one side, how was this capacity like, and scale of quality of life, and also well how they report the pain. And it is interesting that we see the patients in this scale you have here in the slide. So we have here patients with good, I mean, poor sleep and non-poor sleep. And those patients with a lower record here, they had a poor sleep, but they refer no pain. So it could also work in on the contrary. I mean, it's not that the pain affects sleep, but sleep is the one contributing to have pain. Then we have another side here. The psychologists would say, well, I have a patient that tells me that he has back pain. We know many of this. But these patients with a feeling that things are not going to go well will not go well. I mean, we have many studies allowing us to have this meta-analysis. Those patients who go through surgery and they think that it will not go well, the evolution will not be good. So here, we can act here in three different aspects in the patients at the level of neuromodulation. We can provide them some benefits. But then in the spinal pathology, we have different things to take into account. First, what is the source of pain? If it is due to the degeneration of the joints, the degeneration of the disc, this is what generally happens. Or if we have pain due to a compression of nervous structures, and in this case, we have to define what kind of pain it is. If it is only pain, it could be a pain without nervous compression, facet pain or disc pain. So we have to take all this into account and many things to bear in mind. But if we have nerve damage, we have to value to assess the patient with a different perspective, because this tells us that the nerve is suffering and will go on suffering. So that when we see a patient and we see this kind of RMI, we see here a clear example of how it is degenerative spinal. We see the discs, we see here the osteocytes. So when we analyze these inflammatory changes, first we see, I mean, we have three different degrees: inflammation, and then a degeneration into fibrosis. So modic one are related to worse evolution. Patients that go through surgery due to a disc hernia, these are those who don't improve very much after a surgery. Here we have a patient of 4 years old with a hernia, a disc hernia. And we can see here, for example, these patients of evolution, in these cases, are better. But what happens with patients with this disc hernia? They have no loss of strength, loss of sensitivity. So the conservative treatment could be a very good option, because in the studies made in the follow-up of patients with surgery and without surgery, and most of them improve after surgery, but 2 years after the evolution is the same, with or without surgery. Another thing is that you want to live with the pain these 2 years. This is what I tell patients. I mean, And you don't need to go through surgery if you don't have a loss of strength, but you will have pain. So if you want to stop this pain, you will have to go through surgery, right? But then we have other, you can see this in patients. We see patients with a pain that have had for a long time, and then they realize that it is limiting their quality of life, and they start thinking, I mean, these patients who cannot go out with friends, who go away on a trip, go to the movies, to the restaurant, what can they do if they have an episode of pain? What can they do? So these patients stop going to places, remain at home, and this starts generating a circuit of bigger complications. These patients could be benefited from neuromodulation. However, we have cases here, for example, in the which would be the bad and the ugly in the history of this case, because here we shouldn't wait. In this case, there are patients that maybe they didn't know they have some pain. They didn't neither have any image test, and we can see this very clearly in people, especially women. So they start losing strength in their hands, and they come to us with this image. So this is cervical injury. This case must be, I mean, we must fight against decompression in this case. So I would say the following. If the patient comes to your clinic with a feeling of pain, you must tell them very clearly what is the source of this pain. If this is an irradiated pain and has no loss of sensitivity, loss of strength, then you could go for a conservative treatment. If we have loss of strength, we could go for a surgery solution. So patients, I mean, we should prefer to avoid the clinic if he's not going to improve or they are not going to improve. For example, in hernias, if they have this pain but have no loss of strength, we could go for a conservative treatment, neuromodulation, physiotherapy, and see what is the response of the patient. Well, it depends very much on the patient, because if the pain is unbearable, they will say that they want to change treatment. So we have many different options with the patient, and we have to see what is the response to the treatment they are given. But then there's a question: what happens with the patients that make the decision to go through surgery? Is there anything else we can do with neuromodulation in this case? Well, in this case, the evidence is being developed, but there is a study in hip prosthesis, which is very complex. They have valued the heart rate frequency in 3 moments of the day: morning, noontime, and night. So they see that if you only measure this HRV in the evening, there is not much change. They did this follow-up until up to 9 days before surgery. But what happened with this HRV in the morning and at night? So after surgery, the variability would drop. So, so maybe we could prepare, get ready these patients for surgery. I mean, they will always have a stress factor with this surgery, but they will be more prepared. It is true that at the level of cardiology studies, I mean, we have more studies in this field, but we must assess, value the symptoms after surgery, and also study what patients want. I mean, the patients that with a low HRV before surgery usually have less complications after surgery. At the level of neurosurgery, we'll have very much. The worst prognosis for patients with low HRV. So we must know what is our starting point. So it is very important to know. So if we all had, we should know what is our HRV, our variability of the heart rate. So maybe I am a bit stressed now. I could be altered. If I do it at night, that I'm more relaxed, go better. But we always have some variation, some alteration. But it would be interesting to see that both if we start from a poor HRV, maybe we will have a poor prognosis. So we must study this. So at the level of surgery, as you can see, we have here specialists in this with us. This is something that can allow us, can allow a very important development in our practice. When I started out in my clinical practice, I started on my own. I wanted to introduce this technique, this technology, and offer this to my patients, to those who I couldn't provide a good solution, a good surgical solution. I wanted to give them an alternative. First, I started on my own. I used to work with my patient and with my device, NESA, and I used to do the follow-up. So, in the end, you need some help because this is a lot of work in being a surgeon and doing this treatment of 1 hour with the patients. And this told me that we had not, that we should have more interaction between the specialists. Now I can do the follow-up in a different way, can provide appropriate treatments, and I have seen results that maybe I didn't expect. And when I speak with other therapists, they didn't expect it either. So having these tools available and not knowing them very well, I mean, this is not a good thing. We cannot specialize in just one area. We cannot work on just one sector of the spine. We are acting on a body, on a whole body, not only in a fragment. And if we have this tool that can act in a global way in the body, this will help us a lot. And we should apply all the possibilities in our daily practice. Thank you. Thank you very much, Santiago. Well, I'm receiving some questions here. So let's start with the first one. This would be, which is the best moment to apply NESA, after or before surgery? Well, as we have seen in the study, I think it's very important to start before surgery, because if we start from a poor situation, we will have a poor response to any stressing factor. So as soon as possible, when the patient knows that they will have surgery, that they will go through surgery, they could start using this NESA technology. What to prioritize in the modulation of this spinal pathology? Well, this is a very interesting question in terms of, I mean, of all the programs you use for different conditions, I mean, you are not treating only one symptom. No, you're not treating only this radicular pain. So we have different factors. We can have a poor sleep quality, constant anxiety, and this is chronifying the pain. So maybe you should treat this before treating just the pain. If we only treat the pain and we have another factors that we are not treating, if we not provide the patient with an exhaustive, integral approach, I mean, it is not only treating pain. We should go for stress, sleep, as I told you. We need to provide the patient with information, and because they can think that they will live forever with this pain. We have to give them information to improve. What other benefits have you found in terms of neuromodulation in surgery? Well, with the patients at the surgical level, I have experience, for example, with a woman that went through surgery on different occasions with spinal pathology, and she came to the clinic again with lumbar pain. Well, she didn't want to go through surgery because she had had bad experiences before that with the anesthesia. So with NESA technology, I mean, she improved a lot. And at least she spent some time without surgery. What happened after? Well, this woman at the economic level, she couldn't afford to have these sessions regularly. So when she stopped the treatment, the pain came back. As I was telling you before, with the apnea, for example, we need to see things at the structural level. So a patient with an hernia, you have to tell them you have something at the structural level, something that is compressing the nerve and is the source of the pain. So until we treat this, you will not, you will keep, we will not be able to stop this pain. Another experience I had is with a young girl, boxer. She had a traffic accident. Her life became a chaos. When she came to me, she came with a treatment of morphine, and her husband, I don't know how, but he would provide her with this treatment, this morphine. And I told, this is crazy. I mean, this girl is going to die. So she was not having any response because she was doped all day. She was been using this huge amount of drugs, and then we started working with her. We went from 10 to 5 doses a day. I mean, we cannot make miracles. If we start dealing with a patient with a lot of alterations, I mean, it is not easy, but we can always offer them some improvement. And there's always different alternatives of treatment. Okay, the next question has to do with the part of the structure you are commenting. So what could NESA contribute to a nerve that is structurally compressed? Well, this compression is degenerating. So it depends on the moment you start working on this nerve. For example, now I have a patient with face paralysis. Well, she wanted to improve the movement of her face, right? And I told her, well, the movement is not going to improve. This girl, in the end, had to go through surgery. But what was the benefit for her? First, anxiety. We improved a lot her anxiety. This was good for her treatment. But while I was treating her with this, she started to feel that she had lower spasms. And now she went to surgery in February. I saw her last month. She told me that when she had the surgery, because she went to Madrid, and they didn't expect so quick motor response. She had already quite symmetric movement of the lips, of the face. She could smile, she could chew. So at least this reparation of the nerve could be quicker, could go faster. So And so we can work on all type of damage on the tissue with neuropathies. So, for example, I use a lot Channel 5 for this kind of recoveries. And then we will talk about the part of the sports, which is also very important. But I see many patients with this claudication, and they improve a lot with this. Very good. Now, even though your field is surgery, have you seen changes in the sleep? Talking about sleep disorders. Well, I know nothing really about sleep disorders, uh, but I started to deal with these patients. You have a response. I mean, they have a response which is can vary in with the time, and will provide different outcomes. It's like saying a patient that they have to do exercise and diet, and she only or they only do one thing. I mean, regulating these sleep disorders is not easy. Sometimes they could tell you, sometimes I get to sleep at 2, sometimes at 10. I mean, this crazy way of sleeping. And this is not easy to change, these patterns of sleep. So you need to correct all the vices, all the bad habits, and this will help the brain to restructure. And the same happened with the muscle injuries and other pathologies. So if you don't change the source of the damage, you will not have an improvement. These alterations will go on and go on. Okay, next questions are related regarding to pain. Sometimes pain protect us from not doing some gestures. So this is a defensive mechanism. So how you try to avoid this so that the patients can move freely? How can you lead with this? Well, what we have to do is, if this pain is due to a reflex, we need to do a different approach. It must be a holistic approach, not only neuromodulation, but also a muscle training, which is appropriate. But what happens with patients with pain that cannot go to these rehabilitation exercises? So it will be different here. We have to see each case. Now to the last question. Have you found any radiculopathy with compression? Secondary to compression. Well, always that we have a compression. I mean, related to pain in this case. If there is compression, you will have radicular pain. This is always like that. What happens many times when you have an MRI, this is done with the patient lying, so there's no load. So now we are working with MRIs done standing. And this would give us different results because in this position, the nerve would be suffering, not when you're lying. But the radicular pain is not a pain. I mean, we have to see exactly what is the pain. It's also the sensitive alteration. We need to see what is the muscle which is altered here. When we talking about a patient with maybe a patient of 80 years old, I mean, she cannot bear the pain anymore. I mean, they would do anything because we can have, I mean, big loss of blood also in these surgeries. Up to 2 liters of blood we can lose in this type of surgery. So many times in this range of age, I mean, we usually work between 45 and 55 years because old people would not refer that lumbar pain, but more this radicular pain due to degeneration. You have to be very careful because you could make stable spine to become an unstable spine. So very good. I would spend all afternoon listening to this, but we need to continue. So as Socrates said, knowledge begins in wonder. And I want you to have this wonder, as I did, so you can acquire some unimaginable effects. Thank you very much.